And during that time, Mammen won nearly every award for every subject. So much so that I think, if I'm not mistaken, he even won the Obs and Gynae award. And we girls used to feel very ashamed. And I remember for our graduation in 1973, my father came for the graduation, and Dr. Mammen used to walk up the stage on one side, get down from the other side, and again his name was called. So he went round and round. He didn't have time to sit down also. Without exaggeration, I'm not exaggerating. And so that my father, after the graduation, he only remembered one name, and that was Mammen Chandy. And I thought he might even forget his daughter's name. So Mammen has won laurels not only during his undergraduate, but also during his postgraduate education. He went on to do MD medicine in Vellore, and then he did hematology from Australia, Sydney, Australia. Then he was awarded the fellowship of the Royal College of Physicians, London in 2010. And he was a faculty member in CMC Vellore, and he is the one who established that department of hematology and also started DM hematology in Vellore. And in the whole of India, he's had the most number of successful bone marrow transplants. Of course, he won't tell you all this, that is why I have to tell you. Because he will, if you ask him, he says, no, I haven't done anything. That is Mammen. I know him for 49 years. Then he retired from CMC Vellore in 2009, and since then he has taken over the director's post of Tata Medical Center, Kolkata, and people in the north now are very happy that they don't have to go all the way down to Vellore, but they can go to Calcutta. So we are also very happy about it, because there are many patients whom we refer to Calcutta. He is the current chair of the Human Genome Task Force of the Department of Biotechnology, Ministry of Science and Technology, Government of India. And he has special interest in aplastic anemia, thalassemia, leukemia, and of course stem cell transplantation. But besides this academics, Mammen was also a good speaker. Otherwise, he was a speaker of the Men's Hostel Union and also a speaker of our College Students Union. So I can speak for hours and hours about Mammen, but of course time doesn't permit me to do so, and I am very grateful to Dr. Vinay Agarwal to arrange for this meeting, and of course with his team of Dr. B.K. Mishra and Dr. Sharad Verma. Thank you.
Now I request Sir to please start the talk. Good evening, friends. I'm sorry we are late and we kept you waiting. I come here today because of a special function organized in memory of Arthur, that's Premila's husband. They've been good family friends, so we just had to come to Allahabad today. And you know, it's such a pleasure for a doctor. Today at the service, there was a couple and they came. I didn't even remember, but my wife remembers them very well. The child was admitted with aplastic anemia in Vellore, and on the mobile they showed me 12 years later, handsome young man doing B.Tech in Bombay. So can you imagine as a doctor what happiness it is to have contributed to do that for somebody. So today Premila told me that I shouldn't keep it highbrow, So I'm going to be very, very basic, and this talk is meant mainly for physicians. So it's divided into two parts, and the first part is how to approach anemia. So anemia is a very common problem. All of you as physicians face it. So I just want to give you some insights into how to do that. The second part is an approach to bleeding disorders. Since I might forget, I want to thank Dr. Mishra for having come all the way to Varanasi to pick me up and providing snacks for us on the way. And I want to thank Renee, who I have known for many years, for this invitation to your center. So let's get going. So there are two approaches to anemia. One is a clinical approach. The other is a laboratory-based approach. So if Pramla is sitting in the lab and sees a hemoglobin of 5 and looks at the blood film, that's a laboratory-based approach to anemia. But you as a clinician who sees the patient should approach it in a slightly different way, and I'll show you why. So if you approach a problem correctly, you really cannot go wrong, right? So if the lab is looking at a blood film, they will divide anemia into 3 types. One is microcytic, based purely on cell size. 2 is macrocytic, and 3 is normocytic. 3 types based on cell size. So if it's microcytic, there are really only 2 diagnoses. One is thalassemia and the other is iron deficiency anemia. Correct? Microcytic anemia, really 2 causes. The others are quite rare. Anemia of chronic inflammation, you must keep in mind, because there also it's an iron deficient state for the erythroid mass. Macrocytic is really 2 main causes, B12 and folate deficiency. Otherwise, you see a macrocytic anemia in liver disease, in myxedema, sometimes in an autoimmune hemolytic anemia, right? And the third is where you have a normocytic anemia. Cell size is normal, right? I've had a nephrologist refer to me a patient with a hemoglobin of 5. Creatinine was not checked. The creatinine was 12. So the cause of the anemia was renal failure. Okay? So normocytic anemias, generally it's blood loss, renal failure, enzyme defects. These are the cause. But that's the approach which the laboratory uses. Now, one of the most important things as a physician, when you get an index coming out, now every laboratory has these machines. So the machine will give you a mean corpuscular volume, right? So as a physician, always look at the MCV. And a reasonably good machine will give you an accurate MCV, right? So if the MCV comes at 65, this is microcytic anemia. And your 2 main differential diagnoses is thalassemia and deficiency. It's pretty simple. MCV comes as 110, right? It has to be either B12 folate. Now suppose the MCV comes as 140. What will you think of? It's just too high. That means the machine is counting 2 cells stuck together as one, which is why the size is coming so high. So if you get a 140 MCV, almost certainly you're dealing with a autoimmune hemolytic anemia where cells are clumping together, which is why the machine is counting them as such a high MCV. A B12 folate deficiency will not give you an MCV of 140. That will happen only in an AIT. So just by looking at the MCV, you can make a diagnosis, right? So as a physician, always look at the mean corpuscular volume. That's why I've highlighted it in this printout of the red cell indices, right? And today now we have fancy machines which give us scattergrams and all sorts of things. But basically as a physician, as a pathologist, you need to look at all of this. But as a physician, you you need to do this. Today, one of the doctors in the medical college said, asked Pramila, can I ask, my sister is having a problem. So I said, what is the problem? So he said, platelet count is low. Right? So how low? 60, 70,000. Any bleeding? No bleeding. Periods are normal, absolutely no problem. Right? So, what is the thing you ask? You ask, are these platelets so big that the machine is not counting them? That is why the count is low. And the patient is absolutely well, which means don't do all sorts of things. I have patients like this being treated as ITP with steroids and where there is no disease producing a disease. Right? So, low and there. So, nowadays the machines can give you platelet size. It's called mean platelet volume. MPV high, low platelets, 70, 80, 90,000. Patient is absolutely well. It's a condition called constitutional macrothrombocytopenia. Genetically, they have large platelets and they have no problem, and please don't do anything to them. Even if they come to you for surgery, you can happily go ahead and operate without giving them platelets. Okay? So, the clinician should approach anemia slightly differently, right? And I use this when I teach medical students, right? That's a basket full of tomatoes. And that is your circulating volume with all the red blood cells, right? And this is the factory where the red cells are being produced, right? So you can see here, that's the tomato field where all the tomatoes are growing, right? So normally, certain amount of tomatoes are being consumed, good production is there, the shop has enough tomatoes, your hemoglobin is alright. Steady state, right? Certain production, certain destruction, everything is perfect, right? So what's happened here? There's a drought, there's a pest, the tomato production has stopped. Consumption remains the same, but because there's no production, no stocks coming to the market, the level of tomatoes in the shop has come down. Lastly, tomato production is fine, no problem. But it's Diwali, everybody has bought all the tomatoes. So, the level of tomatoes has fallen. Right? Now, if you remember this as a clinician, you will never go wrong in your approach to anemia. Right? Now, what is the one test that can tell us that the bone marrow is alright, there's no pest, there's no drought, the bone marrow is producing, and that is the reticulocyte count, right? If the reticulocyte count is 20, please don't do a bone marrow test. It is not going to help you in any way. The factory is alright, right? Production is alright. It has to be a consumption problem, right? Now this is one test which is not easy to get accurately from a laboratory, right? Because today there are machines which can give you accurate reticulocyte counts, but they are expensive. Reagents are expensive. So you are dependent on Pramila doing a methylene blue stain and counting and telling you the retic count. But if that's done correctly, you have to make a correction for the reticulocyte count based on the hemoglobin, and that I won't go into right now. So this slide sums up everything. So you have a person with anemia. You ask yourself, is it a production problem? Is it a loss problem? Right? If it's a loss problem, there are only two ways you can lose red blood cells. One is hemorrhage and the other is hemolysis. No other way. So all anemia has to be either because the red cell is not making red cells, the bone marrow is not making red cells, or the red cells are being produced and are being lost because of hemorrhage or hemolysis. Right? So decreased production, increased loss. Increased loss, only two causes, hemorrhage or hemolysis. Right? So where can you bleed from? You can bleed from the GI tract, you can bleed from the uterus, you can bleed from the kidney rarely, I'll give you one example, and others which I'll come to in a minute. Hemolysis is of two types. One is congenital, that means it's a hereditary disorder, or two, it's an acquired disorder. Right? Now come to the other side, decreased production. Now suppose there is reduction in red cells, reduction in platelets, and reduction in white cells. Then you call it pancytopenia. And the causes of pancytopenia, I'll tell you in a minute. Now suppose it's only anemia. White cell count normal, platelet count normal. Right? Reticulocyte count low. MCV normal. That means it's a production problem. So if the retic is low, there's anemia, white cell count normal, platelet count normal, then you go to the factory, which is the bone marrow. Now if the bone marrow has no red blood cell production, the diagnosis is pure red cell aplasia. Right? And that can be of two types. Genetic, which we call Black-Van-Diamond syndrome, or acquired due to drugs or due to parvovirus or due to various other things. Right? Now suppose you go to the factory, bone marrow. The bone marrow is full of erythroid cells. Then, and your retic is low. That means it's like a factory where the workers are on strike. They are there, but they are not doing what they are supposed to do. Diagnosis, myelodysplastic syndrome. Right? That means there is dysplasia. That also can be of two types. One is genetic, it's called congenital dyserythropoietic anemia. Baby has come to you, baby has got anemia, reticulocyte count is low, normocytic, not thalassemia. Right? Go to the bone marrow, full of erythroid cells, but all dysplastic. Diagnosis, congenital dyserythropoietic anemia. Baby has come to you with anemia, reticulocyte count low, you do a bone marrow, no erythroid cells. Diagnosis, Black-Van-Diamond syndrome or pure red cell aplasia. Right? So isn't anemia absolutely easy to diagnose? Right? Production problem, loss problem. Loss problem, only two causes. Hemorrhage, hemolysis. Right? Production problem, no erythroid cells in the bone marrow, pure red cell aplasia. Full of erythroid cells, acquired is MDSRA, genetic is congenital dyserythropoietic. So what are the two essential things? A history to ask the question, is it a production problem, is it a loss problem? Second, MCV. Third, reticulocyte count. From that you have decided it's production or loss, and then you work out what to do subsequently. Right? So decreased production, increased loss. And these are the sites from which you can lose blood. And the most important is the GI tract. I've had one child whom I looked after for many, many months. Right? Anemia, anemia, anemia. Right? MCV low, iron deficiency. Kept giving him iron. Till one day he came with an intussusception, and the cause was a hematoma which had caused the intussusception. He lost out quite a bit, right? And your approach must be right. And I'll come to that a little further. Now suppose you have a low retic count, then you know it's a production problem. And if it's all three cell lines, then it's pancytopenia, and I'll give you the differential. If it's only red cells, I've told you, no red cell precursors, it's Black-Van-Diamond in the child, in the adult it's acquired PRC. If the bone marrow is full of erythroid cells, it's congenital dyserythropoietic anemia, or MDS, which is sideroblastic anemia, or MDS. These are the causes of pancytopenia. When I ask a doctor on rounds, says the patient's HP is low, white cell count is low, platelet count is low. Right? Again you ask yourself, all three cell lines are down. Why? Is it a production problem? Is it a loss problem? If it's a loss problem, there are only few causes. Production problem, go to the bone marrow. Cause 1, nothing in the bone marrow, empty, aplastic anemia. 2, bone marrow is full of stuff which shouldn't be there. Leukemia, lymphoma, secondary tumor, granuloma, fibrous tissue. Right? 3rd, bone marrow is full of cells but they're not doing what they're supposed to do. Diagnosis, megaloblastic anemia or MDS. Right? And the second cause where you can get pancytopenia. Patient comes to you, he's got liver disease, got a huge spleen, white cell count 2000, platelet count 30,000, HB7. Diagnosis, hypersplenism. So it's actually quite simple, right? Now, I said the second cause of loss is hemolysis, correct? Now, what are the clinical signs in a person with anemia which will tell you that this is hemolysis, right? One is if it's long-standing. Example, like a thalassemia. So you will have frontal bossing, parietal bossing, right? Those are the signs which will tell you that this is a long-standing hemolytic anemia. Second is jaundice, right? Third is urine which is supposed to be colorless. Okay? So I'm going to ask the audience, do you have anybody with hemolytic anemia who actually tells you that the urine is colorless? Because all the books, when you teach your medical students, you will tell them acholuric jaundice, correct? So when I was a medical student, we had a teacher called S.J. Baker, a very famous hematologist. And he would expect all of us to see every case in the ward. And he'll just pick one student, you present the case. Obviously you did a round before he came. The person who worked up would tell the other students what the case is. So he had this habit of asking students a question, right? And he looked at all of us and said, what is the color of the urine in a hemolytic anemia? Now most students will not give an answer, right? So we all kept quiet. If you don't know, we don't know, sir. It is tea-colored. He was an Australian, right? Yeah. Tea-colored urine, Coca-Cola colored urine. So I knew a little biochemistry in that day. So I said, sir, why is it tea-colored? So he looked at me and he said, because of the pigments in the urine, of course. So I persisted and said, sir, which pigment, sir? So he looked at me a bit stunned now, because no student ever asks Dr. Baker a second question. Right? So then he made the biggest mistake of his life. He said, urobilinogen. So I looked at him and said, sir, it is a colorless compound. So do you know what that taught me? It taught me one lesson which I'll never forget in my life. No matter how big a dada you are, right? You will never know everything. And there will be lacunae in your knowledge which some chota student can pick up. Have the humility to recognize that, right? So it was a terrific lesson for me. That is why I'll never forget. Now what he said is correct. The urine is tea-colored. But it's not because of urobilinogen. It's because the urobilinogen gets oxidized in the bladder itself to give you urobilin, which is cola-colored. Now all the books say echoluric. No student is explained why it is tea-colored. That actually the urobilinogen gets oxidized to urobilin, and that's why you get the characteristic color of the urine. Okay? So these are the signs of hemolysis, right? Jaundice and anemia should immediately make you think of, could this be a hemolytic anemia? Okay? What are the laboratory indicators of hemolysis? First is an elevated retic, right? Second, a bilirubin which is raised and unconjugated bilirubin. Right? So I'm going to ask you all one question. 16-year-old boy comes to me and says, sir, I've been having jaundice for such a long time. Right? Hemoglobin 14, reticulocyte count normal, bilirubin 16. Diagnosis. He's perfectly well, but he's deeply jaundiced. Who's going to tell me? Gilbert's syndrome. Okay? So, anemia with normal HP, normal retics, and unconjugated, then it has to be Gilbert's syndrome. Right? Anyway, so coming back. Reticulocyte count, raised bilirubin, this test we don't do, raised LDH. Please look at the LDH. Now this is one test that very few physicians ask for. It's a fantastic test to ask for, because if your LDH is normal, then the patient really cannot be having severe hemolysis. Okay, it's a very useful test that physician should ask for. It costs a little bit, it's a little expensive test. I think the labs charge about 200, 300 rupees, but it's well worth the money because it helps you to interpret many things. Okay? Now the other tests I'll leave out. As I said, the causes of hemolysis are only two: genetic or congenital or hereditary and acquired. Right? So genetic is only three causes: red cell membrane, hemoglobin, red cell enzyme. Finished. Right? So membrane, hereditary spherocytosis. Hemoglobin, hemoglobinopathies and thalassemia. Enzymes, G6PD, PK, all the rest of it. Right? Acquired hemolytic anemia is only two types: autoimmune and other. And the other is a big basket. Right? Patient comes with malaria, he could be having hemolysis. Right? So I ask medical students, when I teach hemolysis, I ask them and I give them stories. So I'll give you the stories and you will make a diagnosis. Okay? Young lady works in the fields, she's very unhappy with her husband, and she consumes a poison and comes to the emergency with severe hemolysis. Diagnosis: agricultural worker, something which is used in agriculture which she consumes with suicidal intent and comes with hemolysis. Diagnosis: copper sulfate poisoning. Okay? They use copper sulfate as a fungicide. Right? Second, little person who decides that she wants to get rid of a baby, goes to a quack, comes extremely sick to the casualty with a hemoglobin of 5. Diagnosis: we don't see it nowadays. Clostridium welchii infection. Right? Don't forget malaria as the cause of hemolysis. Okay? A young man, he is not a very good character, has a cold bath and passes red urine. Diagnosis: rare condition. I've never seen one in my life. Paroxysmal cold hemoglobinuria. Patient has a prostatectomy and the urologist called saying hemoglobin is falling and the urine is wine colored, not like hematuria. Diagnosis: osmotic hemolysis. Right? Sometimes instead of using glycine to do a prostatectomy, they use distilled water. Why not saline? Because you can't see properly through the saline. Okay? So these are all the other causes of hemolysis. And generally the history will point to that. But there's one condition which you must keep in mind, and that's a condition called PMH. So for me, if it's a hemolytic anemia, acquired hemolytic anemia, it's either an autoimmune, in which case I do a Coombs test. Coombs test is positive, then I know that this is an immune hemolytic anemia. And these are all the miscellaneous causes that I told you about. Right? So what are the tests to establish the cause of hemolysis? I think the most important is a blood picture, and then I've given you this list of causes for hemolysis. Anybody? Diagnosis? Very simple, right? blood film of a 3-month-old baby with severe anemia, right? That I've given the title on top. Nucleated red blood cells, right? Severe hypochromic microcytosis and target cells, right? Diagnosis is thalassemia. So 3 grams hemoglobin at 3 months of age in India, the most probable cause is thalassemia major, right? Now, as physicians, please send a test to the lab before transfusion. If you send the test after transfusion, it's difficult to make a diagnosis because the hemoglobin F level comes down and you have a problem. So we today do the test is not by electrophoresis, the test is by HPLC. This is the Biorad machine and it's an automated machine. This is a heterozygous carrier and this is, see, you know, looking at the MCV is so good. You're a physician, patient comes to you, right? Just comes for a feeling little weak. You do a hemoglobin and it's 9.5, right? And you do the MCV and you find the MCV is 65, right? You do 2 tests. One is a test for thalassemia carrier status and the other is for iron, right? If you pick up the raised A2 as I'm showing here, you have diagnosed thalassemia carrier. In which case, you can prevent the couple, when this person gets married, check the spouse and make sure that the spouse is not a carrier. Okay? As a physician, you have the opportunity to prevent the birth of a baby with thalassemia. Diagnosis, sickle cell anemia, right? The blood film is really a very useful test, right? This is hereditary spherocytosis. You can see the spherocytes present in the blood film. This is an autoimmune hemolytic anemia where the cells are all clumped together. Now the Coombs test is the most important test in an acquired hemolytic anemia, right? We are looking for the presence of an antibody on the red blood cell in a direct Coombs test, and we are looking for an antibody in the serum in an indirect Coombs test. Okay? Please remember both direct and indirect. Okay? Patient comes to you, right? The doctor for some reason orders a Coombs test. The indirect Coombs test is positive. The direct Coombs test is negative. So what's your diagnosis? There's an antibody in the serum. It is not present on the patient's own red cells, which means it's an allo antibody. It's not against the patient's own red cells. It's an allo antibody, which means this is a lady who's had a previous pregnancy or somebody who's had a previous transfusion. Correct? Indirect Coombs test positive. Direct Coombs test positive, then it means that there is an antibody directed against the red blood cell. But please remember, whenever you do a Coombs test, check whether the patient was transfused. If the patient was transfused and the Coombs test is positive, it may be an alloantibody against the transfused cells and it may not be an autoantibody. Okay? This is a patient with a DIC. You can see there are fragmented cells and microspherocytes. This is another cause of hemolytic anemia. So basically, for anemia, what do you need? You need a physician who is thinking correctly, who asks the question, is it a production problem? Is it a loss problem? You need to do the right test. The right test would be a mean corpuscular volume and a reticulocyte count, right? Then you know the direction in which to go and you cannot make a mistake. So it's often the physician who's refractory and not the anemia which is refractory. Okay? So if you approach it correctly, you won't have a problem, right? So if you can approach anything systematic, you know, when I take rounds, I'll ask, what is the cause of this patient's anemia? The doctor who tells me and analyzes it, production, loss, then I know this guy is thinking on rounds and he's approaching the problem correctly. Okay. One case just to illustrate the problem. A 4-year-old male child born to non-consanguineous parents, weak, pale, shortness of breath. Okay? No history of bleeding from any site. Carefully taken history. Right? Normal dietary intake. Eating like a 4-year-old child should eat. On exam, he is pale, his liver and spleen are not enlarged, and his systemic examination is normal. Right? This is his blood film. Pathologists can quickly make a diagnosis. No? Right? What I should have given you a lymphocyte, because you really can't be expected to size the cell without a normal lymphocyte. But you can see some pencil cells, you can see hypochromia, severe hypochromia, and I will tell you there's microcytosis. So it's a hypochromic microcytic anemia. Correct? There are no target cells, there are no nucleated red blood cells, so most probably this is going to be iron deficiency anemia. So what do? Right? You send off a serum iron and binding capacity, you do a ferritin, right? And subsequently, these are rarer tests which I won't do straight away, right? So this boy's serum iron is 32, his TIBC is 312, his saturation is 10%, and his ferritin is 4. Right? Everybody is happy? This is plain and straightforward iron deficiency anemia. Ferritin low, saturation low, and there can't be anything else, right? So this is the interpretation of iron in relationship to TIBC. Normal is 30%. When you're iron deficient, your TIBC tends to go up and your serum iron comes down, so the saturation is low. In anemia of chronic disease, the TIBC remains normal, right? And you will find that the TIBC comes down, the iron comes down, so the saturation remains normal, right? This kid, we actually did a bone marrow, right? And there's no stainable iron in the bone marrow. So we confirmed iron deficiency. So what's the next step? Confirmed iron deficiency. Next step, right? I told you, he's eating normally, he is not bleeding from anywhere. So I need to be sure as to what the cause is. Okay? 40-year-old school teacher comes to hematology department in CMC Vellore, right? HB 6, MCV 65, iron low, diagnosis iron deficiency anemia, right? Questioned, periods not heavy, dietary intake good. What's the next step I must do? Physicians. 40-year-old lady, teacher from Kerala, well-to-do family, comes to me in Vellore with anemia from a good socio-economic group, right? So what did I say? Production or loss, right? So in this particular person, I have confirmed iron deficiency. So I must then establish what is the cause of iron deficiency. And in most patients, the cause of iron deficiency, if they are eating properly, is blood loss. And blood loss is from the uterus, from the GI tract, from the kidney rarely, right? These are the main 3 causes. So I did a stool for focal blood. All of you must do that. If you have anemia and you confirm iron deficiency, it is mandatory for you to do a stool for focal blood in any adult patient. Stool for focal blood 3+. Right? So diagnosis, gastrointestinal blood loss producing iron deficiency anemia. Next step, refer to gastroenterologist. They'll do an upper GI endoscopy, they'll do a colonoscopy. Upper GI endoscopy shows an ulcer on the stomach. Biopsy done, no evidence of malignancy. Given some ranitidine in those days, iron supplements, and told to go home and forget about it. Yes, no. Patient came back 6 months later with bilateral ovarian masses. Diagnosis. Lots of pathologists here. Huh? Kuchenberg tumor. Right? So, the physician, if he had only said, no, I am not going to let you go, you must come back after 6 weeks for a repeat endoscopy, we might have been able to do a curative resection of her stomach. Instead, we have a terminal malignancy for which nothing can be done. Right? So, just by the correct approach to iron deficiency anemia. Adult coming with iron deficiency anemia who's from a good socioeconomic status, you must check the GI tract. If upper GI endoscopy is normal, colonoscopy is normal, stool local blood is positive, then you have to do lots of tests to find out the site of bleeding from the small intestine. Capsule endoscopy, angiography, that's the direction you have to go. So don't just say a simple iron deficiency anemia and leave it. Correct? So in this case, this small case, multiple stool focal blood, all negative. Right? So, stool focal blood, we did a urine for hemosiderin, that was negative. Then we did a gastric juice. Right? And this was his chest x-ray. Anybody wants to tell me? It's called biliary mottling. And this is his lung, and this is his sputum for iron stain. Diagnosis, very good. Pulmonary hemosiderosis. Right? So this diagnosis I made 15 years ago. And the patient comes and sees me in Calcutta even now. Right? Pulmonary hemosiderosis. This is the rarest of rare conditions. But it was diagnosed by following the pathway. Anemia, cause iron deficiency, causes of iron deficiency, blood loss, check different sites, finally ended up with the lung, which was the rarest cause. Right? So this kid is on immunosuppression and he's doing very well. If he hadn't diagnosed it, he'd have ended up with respiratory failure. Alright? So idiopathic pulmonary hemosiderosis, rare disease of uncertain pathology and correct diagnosis based, we were able to do that. So I'm going to leave anemia and quickly try and give you an approach to bleeding disorders. Right? So I just want you to remember that one point I told you. Production, loss, causes of loss. If it's a production problem, going to the bone marrow. If it's a loss problem, is it hemorrhage or hemolysis? How to approach hemolysis. Okay? Bleeding disorders, right? I'm going to say a little bit about the physiology of hemostasis, right? Now all of you know that there are three components to hemostasis. One is the blood vessel wall, two is the platelet, and three is the coagulation cascade. Three components to arresting bleeding, right? The vessel wall, the platelet, and the coagulation cascade. Now please remember that whenever you cut your finger, there's a chance of infection. So the body always links hemostasis to inflammation and wound healing. Ultimately the wound must heal, no? So there must be a response, and that is, do you know why we heal normally without a scar? It's because the fibrin allows the fibroblast to grow neatly across and seal the rent. Right? So when I teach students, I tell them, please think that whenever you get clotting, it is linked to inflammation, to fibrinolysis, and to wound healing. When a clot forms, the body doesn't want to permanently lose that blood vessel. right? It wants to destroy the clot and allow blood to flow through the vessel again, right? So hemostasis is unique. It takes place in flowing blood, the tiny stimulus which sets off a cascade, and the system is perfectly tuned. If you go too much one way, you will clot. If you go too little towards control of bleeding, you're hemorrhaging. So in all of you sitting in this room, your hemostasis is perfectly balanced with mechanisms to regulate hemostasis, right? So that's the blood vessel, that's the platelet, and you can see the platelet forming a strand. Now, when you think of the blood vessel, don't think of it as just a pipe. It's not just a pipe. It's one of the biologically most active conduits, right? It functions as a procoagulant and it functions as an anticoagulant. It produces prostacyclin, which prevents the platelets from attaching onto the vessel wall. This is a resting platelet. This is a platelet with its ultrastructure. I don't have time to go through that. The platelet does, first it comes and sticks. Then it collects more platelets. We call that aggregation. The first phase is adhesion. Next, it releases biochemical substances, and that makes the clot contract down. It's almost like a cork which is being pushed into a rent in the blood vessel. Right? So adhesion, aggregation, and clot retraction. This is a platelet. As it adheres, it spreads out and seals the rent. And this is how it catches red blood cells into the clot to form a clot which seals off the rent. Now there is something in your blood called von Willebrand factor, which I'll come to a bit later, and this is important in making the platelet stick to the rent in the vessel. Now the third part is the coagulation cascade. Now this is important because it lays down a fibrin clot. Now when you and I learnt the coagulation cascade in medical students, we learnt of an intrinsic pathway and an extrinsic pathway, right? When I was a student, even in my sleep, I could say 12, 11, 9, 8, 10, 5, 2, 1, okay? Because that was the cascade. So the intrinsic cascade and the extrinsic cascade. And the extrinsic was tissue factor stimulating factor 7, right? And this is how we believe clotting occurred, right? So if you look here, it's the intrinsic pathway, 12 to 12A, 9 to 9A. 9A converts factor 10 to 10A. This converts, in the presence of factor 5 and phospholipid, it converts prothrombin to thrombin. Prothrombin converts fibrinogen to fibrin, and this is stabilized by factor 30. The extrinsic pathway, you have tissue factor, which binds to factor 7 and starts off the cascade, right? This is again shown diagrammatically in a different way. Now this is not how blood clots inside the body, right? Why? Hegeman is the chap who had factor 12 deficiency, right? Do you know what he died of? He died of thrombosis. He didn't die of bleeding. So what we learned as medical students, that factor 12 starts off the cascade, is not correct. Okay? So factor 12 is not the initiator of coagulation. Right? Now why do you need to know this? I'll tell you that a little later. There are no two separate systems, extrinsic, intrinsic. It's linked. So this is the modern concept of coagulation. Coagulation starts with some tissue damage. The tissue damage stimulates factor 7. 7 is the key player, not 12. Okay? So tissue factor stimulates factor 7, which is why today the company Novo is making huge billions of bucks on Novo 7. Right? Because this is the key player. 7 with tissue factor. What this does is that it converts a little bit of 10 to 10A. This then converts a little bit of prothrombin to thrombin. Right? That tiny bit of thrombin now explodes. Right? What does it do? This little bit of thrombin now will convert 5 to 5A, 8 to 8A, 11 to 11A. Right? And this now sets the cascade rolling. It's like a little hole in the dam which now has opened and the water is gushing out. Right? So 7 is the player, 10 to 10A, tiny amount of thrombin. That thrombin converts 5 to 5A, 8 to 8A, 9 to 9, 11 to 11A, and that produces a huge amount. And this is called the thrombin burst. Right? That converts fibrinogen to fibrin and you get a clot. Right? And in the stabilization phase, the clot is stabilized by factor 30. So this is the central role of thrombin in the understanding of hemostasis. So I am afraid that those of you who teach pathology will have to teach pathology in this way, right? Because otherwise your medical student is going to go away with intrinsic pathway, extrinsic pathway, and he would not have reached the 20th century, unfortunately. Okay? So this is the current understanding of hemostasis. And this is essential because when you approach a patient, you will realize how important this is. Okay? And this is shown again in a different way. Now, hemostasis is perfectly regulated. Right? We have 3 substances which prevent the clotting from going out of hand, which regulate it. Right? One is a substance called tissue factor pathway inhibitor, TFPI. Right? Now when a hookworm attaches to your intestine, he wants to feed, no? He wants to drink your blood. How does he drink your blood? Because immediately it will clot, no? So the hookworm produces tissue factor pathway inhibitor. It prevents the activation of 7, and that's how it gets its feed. Most of the anticoagulants we have come to us from blood-sucking insects. Leeches give us hirudin, right? The various ticks give us anticoagulants, right? So the hookworm sucks blood by TFPI. Second, we have something called protein C and protein S, which regulates factor 5 and factor 8. And the third, we have antithrombin 3. These are the 3 naturally occurring anticoagulants inside our body which actually maintain the fine balance between thrombosis and this is the positive feedback, this is the negative feedback. I've told you about that. Now once a clot forms, it is necessary for the body to break down that clot. And that initiates fibrinolysis, right? And that is done through the plasminogen system, right? So the purpose of clotting is to lay down a clot to seal the rent, not more than that, right? So most often the hemostatic system is like a man walking a tightrope. On one side there's a shark of bleeding. On the other side there's a shark of thrombosis. So just imagine how beautifully God has made us to make our system so perfect. And when one little thing goes the other way, my professor of hematology in Vellore had a problem where you take blood from him and he clots, and that clot goes to his lung and gives him a PA. Multiple DVTs, recurrent thromboembolism. He's got an IVC filter in, right? Diagnosis, he just lacks one little protein called antithrombin 3. So because he has no antithrombin 3, he has clotting shifted to this side. On the other hand, you have a child born with factor 8 deficiency, it's constantly bleeding, right? So just think of how beautifully you and I are, that we neither bleed nor clot. We only bleed when we need to, and we clot when we need to. So how do you approach a patient with a bleeding disorder? The first thing is to take a history. Please always take a history carefully, right? and then do a physical examination, then only asks for laboratory tests. Okay? So this is the order, and the laboratory tests that are useful for screening are a platelet count, a bleeding time, a prothrombin time, and a partial thromboplastin time. Okay? Now today I have taken out bleeding time. Why? It's a very difficult test to do unless you have a good laboratory technician. Right? Number one. Number two, in India, despite us being able to put a satellite into space, we are not able to produce a BP apparatus where if you screw it, the mercury won't come down. Right? So the poor technician who has to maintain the cuff at 60 millimeters of mercury is never able to do that. So you don't get an accurate bleeding time. Right? To do an accurate bleeding time, you only need two things. You need a technician who is reasonably smart, you need a BP cuff which works, and you need a blade, scalpel which will give you a precise incision. Right? So I've taken this out of my algorithm except in special situations. Right? So when I was a student, the surgeon, when he's sending a screening before he's doing a major surgery, what is the test? BT, CT, PT. Is that correct? Even today it is BT, CT, PT. Right? Bleeding time, clotting time, and platelet count. PT, prothrombin time. Okay? So BT, CT, PT. So today please don't do BT, CT, PT. Right? Because coagulation time is a useless test. We don't do it anymore. I had a patient long years ago from Bangalore, the ENT surgeon has done BT, CT, PT, all normal, taken for tonsillectomy, patient bled on the table, arrested, cardiac massage done, developed a hemothorax and came to us with a chest tube and 20 units of blood transfused. Diagnosis, mild hemophilia, which was missed because of BT, CT, PT. Right? So, no longer. Today, screening test for hemostasis is a platelet count, a prothrombin time, and an activated partial thromboplastin time, APTT. Okay? So if you want to genuinely screen a patient before surgery, then it's a platelet count, bleeding time, and not a bleeding time, a prothrombin time, and an activated partial thromboplastin. Okay? So if the bleeding occurred very young, patient comes, his uncle has got joint bleeds, and he has also got bleeding. Diagnosis is most probably a congenital bleeding disorder. Now there are two patterns of bleeding. Bleeding from the mucous membrane and skin, and bleeding from into the joints or into the muscle or subcutaneous tissue. So if your pattern of bleeding is mucosal, then it's a platelet or a vessel wall problem. If your pattern of bleeding okay, so if your pattern of bleeding is skin and mucous membrane, then it's a problem with the platelet or the problem with the vessel wall. If your problem is joint bleeding, muscle bleeding, then you're dealing with a coagulation factor problem. Right? So those are the two patterns. Now most patients, when they tell you about bleeding, will always exaggerate the amount of bleeding. How much blood did you vomit? 1 bucket, sir. Right? That's the standard way, because blood is so frightening that they tend to exaggerate. So then you must ask, did you require blood transfusion? Oh, no, sir, I never had blood transfusion. Then you cannot bleed a bucket of blood and not need a blood transfusion and become hypotensive. Right? So ask that history. Right? Now, under the patterns of bleeding, I've already told you, please check for this type of pattern and you cannot go wrong, right? A lady who says that my problem is menorrhagia, that's mucosal bleeding. You're likely to be dealing with a platelet or a vessel wall problem. You won't get menorrhagia as a cause of in people with factor deficiencies. Not always, you can get, right? So this is a young lad from Tamil Nadu who's bleeding consistently from his mouth. Okay? All the time bleeding from his mouth. His platelet count is normal. His PT and APTT are normal. There's no joint bleeding at all. Diagnosis. Huh? 1 milligram? PT, APTT normal. Huh? Bleeding from the mouth, only mucous membrane. So I said it has to be a platelet or a vessel wall. He has no vessel wall problem. And his platelet count is normal. Therefore, it must be a platelet function disorder. That's the algorithm, the way your mind must work. Patient with mucous membrane bleeding, correct? Therefore, platelet or vessel wall. No hemangiomas, nothing like that. So, platelet count normal, PT, APTT normal means hemostasis is normal, right? It cannot be a coagulation factor deficiency. Therefore, this patient must be having a platelet function disorder. So you have to screen. In Tamil Nadu, lots of consanguineous marriages. So this condition is the commonest platelet dysfunction problem. It's called Klansman's thrombocythemia, right? Whereas glycoprotein 2b3a is absent from the cell surface. Okay? The person with bleeding into both knee joints, his mother's brother had the same problem. Diagnosis? Hemophilia, right? 8 or 9? In terms of commonness, 8. But you cannot say 8 or 9 based upon the history. You have to do a test to confirm that, right? What is the laboratory evaluation, right? As I told you, screening tests are platelet count, PT and APT, right? Now, please don't do coagulation workups if the patient has recently been transfused. It's a waste of money. Second, don't do platelet function tests without checking whether the patient is on aspirin or clopidogrel, right? And you must wait for at least a week for doing and at least 4 weeks before you do major detailed coagulation workup, because one of the factors has a long half-life. Right? So these are the tests, and this is what needs to be done. So it's not this. Now, platelet count, always ask your pathologist to have a look at the peripheral smear and say what it is. 1 platelet per high power field in an area where the red cells are just about touching is equivalent to a count of 10,000. So if you've got 10 platelets in 1 high power field where the red cells are not quite touching, not overlapping, then your platelet count is 100,000. Okay? So 1 platelet per 10,000 is the approximate thing. Now these are the tests for bleeding, which I won't go into because it will take a long time. These are the platelet function tests that we do. This is aggregometry, and this is the laboratory test we do. Right? I'll come back to this in a minute. Right? I'll come back to this with 1 or 2 of the cases. Now, whenever you send a coagulation test, now suppose you send it to Pramila, you asked for an APTT, right? You must always do a correction study. Very simple test. The lab should have frozen plasma, which is normal controlled plasma, right? So you take half of the patient's plasma, half of the controlled plasma, and repeat the test, right? Now I've given you 2 examples here. You can see this patient has an APTT of 54 seconds. You added controlled plasma and the time nearly corrected. This means that this is a simple factor deficiency. You added control plasma and it corrected. You need only 30% of your coagulation factor level in order to get a normal coagulation test. Alright? Now suppose you add controlled plasma and it doesn't correct. Patient is sitting in the thoracic surgery ward, planned for a valve replacement. Right? They have sent 3 times APTT and all 3 times APTT is prolonged. So they send a consult to hematology. So you go to the ward. No bleeding history, absolutely normal. Right? Then you ask the nurse, where did you take the blood from? I took it from the central line. And the central line is heparinized. Right? So if the lab had done a correction study, they would have found that it's not correcting. And if it's not correcting, then it must be that there is an anticoagulant inside the plasma, which can either be heparin or a fibrin degradation product or an antibody to the coagulation factor. Alright? So the correction study is very, very useful. And any laboratory which does a PT-APT should automatically do a correction study. It's a bit difficult because you have to collect at least 10 normal people's plasma, freeze it and keep it. Right? Okay, that's your pathways. And your APTT test, tests 12, 11, 9, 8, 10. So you need to remember intrinsic, extrinsic, because that's how blood clots inside the tube. Okay, so when you teach students, you must teach them the intrinsic, extrinsic also, because that is how blood clots inside the tube. Right? And in order to interpret an APTT test, you have to know that the APTT is like adding activating factor 12, 11, 9, 8, 10, 5, 2, 1. Whereas a PT test is testing 7, 10, 5, 2, 1. Alright? It's testing the intrinsic pathway. Okay, 1 or 2 cases. 21-year-old female with menorrhagia, occasional gum bleeding. Her platelet count is 60,000. Her bleeding time is more than 15 minutes. Right? What is your diagnosis? Platelet count little low, bleeding time more than 15 minutes means she's got a platelet function problem. So which platelet function problem can be associated with a slightly low platelet count? Unfair question to ask you all, but the diagnosis is Bernard-Soulier syndrome. Okay? Now, I've had people with Bernard-Soulier diagnosed as ITP, given steroids and whatnot. Right? So, please think, bleeding time is useful there. If your platelet count is 60,000, you generally don't bleed. Right? So here it's bleeding, that means it must be, and actually the pathologist can make a diagnosis just by looking at the film. Bleeding time more than 15 minutes, platelet count lowish, big platelets, diagnosis is Bernard-Soulier syndrome. And you can do the relevant platelet function tests, right? And that's the way you diagnose. It's glycoprotein 1b9 being absent. Platelet function disorders can be genetic or acquired, and this is the list. These are the drugs you must remember. Okay, second case. 5-year-old male child with recurrent bleeds into the joints, mother's uncle with similar problem, platelet count and bleeding time normal, PT normal. APTT more than 1 minute, half patient, half control, 28 seconds. Diagnosis? So APTT prolonged, right? And this patient has got joint bleeds. So it has to be a coagulation factor deficiency. Can it be factor 12? No. Good. PT is normal. If PT is normal, 7, 10, 5, 2, 1 is normal. 7, 10, 5, 2, 1 normal. Right? So it has to be 12, 11, 9 or 8. 12 never has bleeding, I told you already. Right? So it has to be 11, 9 or 8. right? So you have to do correction studies to say what it is, right? So this particular person was hemophilia, and you can confirm 8 or 9, those are the two common ones, by doing a factor assay. Okay, 24-year-old female with mild menorrhagia, investigated at the time of surgery for appendix. Her APTT is prolonged, but not terribly so, 35 seconds. Her bleeding time is prolonged, 7 seconds. Her PT and her platelet count are normal. What's your diagnosis? Very good. So Pramila, they all seem to know hemostasis. Bone Willebrand's. Okay? And this is it's a difficult disease, okay? There are many subtypes. It's not a simple disease to diagnose, but it's a common disease. So a lady with mild menorrhagia may go throughout her life and be missed with this diagnosis. Okay? Next case, 14-year-old boy with a history of umbilical stump bleeding, keloids, admitted with a traumatic bleed into his right knee joint. His PT is normal, his APTT is normal, his bleeding time is normal, his platelet count is normal. What's your diagnosis? Factor 13 deficiency. Very good. Right? What's the reason? When you clot, your fibrin forms like a thread across the clot, and fibroblasts grow neatly across the fibrin strands. When fibrin is disorganized, fibroblasts grow in all sorts of directions, which is why you get keloid formation in factor 13 and fibrinogen disorders. Okay? And that's how you confirm a diagnosis, by a very simple test called urea clot lysis. Okay? A 14-year-old boy with a history of umbilical stump bleeding, epistaxis, gum bleeding and keloid. His PT is 1 minute. His APTT is 1 minute. His bleeding time is 8 minutes. And his platelet count is normal. His thrombin time is greater than 1 minute. What's your diagnosis? Fibrinogen disease, right? Because both PT and APTT are abnormal, which means it can on 10, 5, 2, 1. The thrombin time is a measure of function of fibrinogen, right? So this is an easy diagnosis to make, right? Next, a female, mild bleeding following a tooth extraction, referred to the hematologist, platelet count and bleeding time normal, prothrombin time 20, control is 12, APTT 51, control is 24, thrombin time normal. What's your diagnosis? So PT and APTT are prolonged. Therefore, it has to be a common factor. 10, 5, 2. Cannot be 1 because the thrombin time is normal. So it's 10, 5 or 2. Okay? But please always remember there is a syndrome called familial multiple coagulation factor deficiency. And the commonest is a combination of factor 5 and factor 8. Okay? So this particular person was a familial multiple coagulation factor deficiency. And these are the things. Okay. A 24-year-old male admitted to the ICU with sepsis, bleeding from multiple sites, PT-APTT prolonged, not correcting. Right? TT is prolonged, fibrinogen is low, platelet count is 20,000. Diagnosis? AIC. Okay? Straightforward. Look at the peripheral smear, microspherocytes and schistocytes present, platelet count low. Not correcting is because there's a lot of fibrin degradation products which are preventing fibrin from polymerizing. Okay? That's a peripheral smear. 14-year-old child, very smart boy, clears his throat and brings out blood. Right? Both parents are doctors. ENT examination done, normal. Every test under the sun done in CMC Vellore and multiple other laboratories in 3 centers in the country. All tests normal, including factor 13, urea lysis, everything. Diagnosis. Huh? Scurvy. Not common yet nowadays. You know, there used to be a doctor who used to teach us, the chap called Teku. You must ask the patient whether he has been on a long voyage without the lines. Right? So that was the olden days called scurvy, right? But anyway, diagnosis. Right? Now this was a picture which came in the Times of India in national newspapers. Right? The story was put as girl who bleeds without being cut baffles doctors. And she bleeds tears. Her tears are blood. Right? Her tears are blood. And this AIMS, every doctor in AIMS has seen her. The parents are going to sue AIMS saying you are misdiagnosed. What's your diagnosis? Munchausen's syndrome. Anybody heard of it? Okay. This is, I see patients maybe 2-3 times a year. And they bleed from the most peculiar places, from the ear. No hemophilic bleeds from the ear. Right? No hemophilic bleeds tears. Right? No hemophilic bleeds from the palm of his hand. Right? So these are all induced bleeding. Right? So that this boy actually was, both parents were doctors. No matter what we told them, they won't listen. How to say that my son is inducing this? Right? So Munchausen was a chap who told a lot of stories, and there are 3 components of Munchausen syndrome. One is hemorrhagia histrionica. That is an example of hemorrhagia histrionica. There is no actual cause. Pyrexia factitia and laparotomophilia migrans. They keep going with pain and having multiple laparotomies. Right? They actually need psychiatric help, not physician's help. Right? So, in fact, I had one nurse, right? When I was a physician, very junior physician, I didn't know much then. Temperature chart 103, 104, right? Even liver biopsy done, can you believe it? So I came to the ward, said, sister, show me the temperature chart. 5 minutes back, temperature is 103. So I look at her, dress is dry, right? So then check the temperature is normal. So please remember, a fever which defervesces without diaphoresis is a fictitious. So this was my first experience of Munchausen syndrome, right? A nurse, she was inverting the thermometer and giving it back to the colleague who was checking the temperature. Obviously deep psychiatric problems which makes this person want to do this, right? So that is my conclusion of what bleeding disorder approach is. Please remember a few things. In a person who's got a bleeding disorder, please do not use NSAIDs or aspirin related drugs. Do not give intramuscular injections. I've had hemophilic patients, doctor relation. Please don't give me IM injection. What now? Who is this who has said this? Huge hematoma, right? So no intramuscular injections. Next, agents which do not help. Calcium. So no matter what the surgeon tells the anesthetist to give calcium because he's bleeding, no. Patient will be dead of tetany before hemostasis is affected by fall in calcium. Okay? So there's no question, right? Vitamin C, streptovit, streptochrome, claudin, botropase, all these agents are of no use at all. Right? So rational approach to bleeding requires understanding of normal physiology, basic laboratory facilities which are reliable, blood components for treatment, and understanding of the pathology in each condition. This is the Tata Medical Center where I work now. It's a beautiful hospital.